Dear brothers and sisters, Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to a new episode of Health from Huda TV. A family with a newborn is a happy family, and everybody's waiting for this child to be born. Unfortunately, some of them are born with a congenital problem that would lead to a surgery or lead to an urgent intervention needed to be done for this child to survive. With us today is Dr. Ahmed El-Debeiky, consultant of pediatric surgery at Ain Shams University in Cairo, who would shed a light upon such problems and how to detect them and how to treat them as well. Welcome, Dr. Mohammed.
Honored to be with you, sir.
A child, a newborn, as the family is very happy to receive them, the doctor would break the news and tell them, we need to do some interventional surgery or non-surgical problem. How's that?
Okay, most of the children are born in a healthy status, and they are examined in the birth room through a pediatrician. The general examination would tell us if there is a serious problem or not. So most of the life-threatening problems would be detected as early as the child room, just at the moment of birth. Some others may not be diagnosed unless the child is suffering from a problem. So what we can say is that some of the problems are evident and some are obscure. Even those of the obscure, some of them became evident due to the routine examination. But still, the remaining group of the obscure type cannot be diagnosed as that early, but will need to be assessed later on when they are starting to have a problem.
So it's true that children at such a very early age would need a surgery. How early could it be? Could it be a few days? Could it be a few hours? How early is that?
Yes, some of these problems would just need preparation and stabilization of the child to be operated upon, and that would take a few hours, and these hours may extend to 24 to 48 hours, sometimes more than that, and rarely would be less than that.
What's the definition of the word newborn? Is it just the one who is born in few days, or how long is the period that we can still call the child a newborn?
Okay, during the first month, this is a newborn, and the second month is also considered to be a newborn. So after exceeding the 2 months of age, we pass them from the neonates to consider them as infants.
So as you've been saying earlier, it's either an obscure problem or an evident problem.
Yeah.
And if it's an evident problem, it might be noticed by the parents, or just as you said, it has to be an examination for every child being born in the examination room just after delivery.
Yes,
Exactly, yes. So, if it's not evident, how would the parents know this problem? How would they notice? What would they notice? And if it's evident, how would be the intervention? I would like you to tell us some examples of both sides, the evident problems and the obscure problems, as you've mentioned, and tell us how to diagnose it, or how to know that does it really exist.
Okay, some of these anomalies would be evident to the eyes of anyone who would see this child. A good example of this is the anomalies of the face. One of these is a common problem, which is called the hair lip. Just like the one that's on the screen right now, we can see that this is a common type where we can have the nose and the mouth in a common communication where the lip is deficient partially or completely, and these are evident to anyone who would see this child at that time. Such a child would have some problems with feeding because he would have a deficient suckling during the early phase of feeding, but this is now maintained through certain devices that are used to facilitate whether the normal breastfeeding or through bottle feeding. And later on, when the child grows to the age of 3 months, then we can just proceed to surgery. We usually do the construction of the lip at the age of 3 months. And if he is having the palate, which is the roof of the mouth and the floor of the nose, we do this bony reconstruction by the age of 6 to 8 months. Another good example of the evident anomalies that can be seen at birth are those of the abdominal wall defects, like the one seen on the screen right now. And this, in that case, part of the abdominal wall, which is the tummy's wall, is deficient, so the internal viscera can be evident. And in such type, these viscera can be covered, the liver and the intestine can be covered with some coverings that are belonging to the fetus, or sometimes these coverings are deficient, so the viscera, intestine or liver can be just floating without any coverings. And in that case, that would need an immediate intervention.
So the child is born with many of the contents of his abdomen, or actually outside the abdomen, exposed to the air, maybe covered with a sac, as you have told us. But there is a hazard that it would be injured. What are the hazards that would happen if this sac stays for a long time? And how urgent do we need to intervene? Are some cases need to intervene immediately? I heard that some cases are even intervene in the uterus itself, even before the birth. Is that one of the causes, one of the cases that we need to intervene?
Okay. If the sac is present, then we are having some time to prepare the child and decide whether his general condition and if there is any other associated problems like those of the heart or the kidneys or other parts, so we can have time to prepare the child properly and decide upon the best procedure to be done to him. But if this sac is deficient and the internal viscera is just exposed to the air, then we can't wait for long. But we have to intervene as early as possible to cover this and protect it from any injuries, further injuries, especially that just its exposure to the air would lead to ulceration and breakdown of the surface. So we'll have to intervene within few hours, and that's real. Few hours.
Yes.
We just have to keep it as moist as possible, and then we'll have to intervene as fast as possible, just to save this intestine.
Yes. And such a surgery, would it be hazardous for a child born at this age? I mean, some of the parents who would be listening to the show now would be afraid that if such a child would go into a surgery, it would be very... he could not stand such a surgery.
Okay. To operate upon a neonate, that's a true problem. But fortunately enough, in the last few decades, the improvement and the development in technology and in medications have assured that such an operation would be undertaken as safe as possible. So nowadays, those children are operated upon when they are still fresh newborns, and they just go smooth. Have some time after the operation in the neonatal ICU, and afterwards they start feeding and they go, hopefully. This doesn't mean that these children are not at an increased hazard, but they are at an increased risk, because some of these may have associated anomalies like those of the heart, of the brain, of the kidneys, and these children did not start feeding and they are having increased demands for nutrients. And so supplying these nutrients through the blood directly, although this is a great improvement that's happened, but still this is not as perfect as those through the GIT system, through the gut system, which provides the best boosting for the immunity of the child and for his growth.
Well, so are there any other kinds of evident problems that you would like to tell us about? which would be obvious for the either the physicians or the parents.
Yes, there are some others, like those of the vascular malformations, and those malformations are consisting of vascular spaces like those arteries and veins and other vessels, or those as well of the lymphatic vessels, and those usually provide a mass, a swelling that has coloration according to its nature, whether it's from an artery or a vein or a lymphatic, which is usually colorless. And in that case, these are quite evident, because if they are affecting the head or the thorax, the chest, then this will be evident. Some tumors would also be evident at the neonatal period, like those of some form of teratomas, which develops from the primitive embryonic cells.
Yes.
And these can develop to any type of tissues, and usually they can attain huge sizes, and these can be quite evident at birth.
Okay, so now that we have some examples of the evident problems that a neonate might face, I believe the other side, the inevident or the obscure ones, would be difficult to know, difficult to diagnose, and I believe it would be quite important to know more about them. We'll be coming back after the break. Inshallah, Dr. Muhammad will be talking to us about other kinds of neonatal surgeries that need to be done in the early life of a child. Please be with us. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum wa rahmatullah, and welcome back to our program Health. Remember, you can contact us at any time at health@huda.tv. With us again is Dr. Muhammad El-Debeiky, consultant of pediatric neonatology surgery, and he'll be talking to us about the obscure problems that a child might be born with and would need a surgery. Welcome back, Dr. Muhammad.
Welcome, sir.
So, at the early part of the episode, we were able to know some of the problems that would be evident for the parents or the physicians, and they will be able to treat it either immediately as an urgent procedure or maybe later on after some preparation. But what about the other types? I mean, the obscure types, as you call them. These would be very difficult to diagnose. Where maybe the child is born, he looks very good, and so the parents would take him back home, and afterwards they need to diagnose it themselves. Maybe they would not be able to go to the physicians until they have some problems with the child. So please tell us some of these problems, and let us know how the parents or the family can know how to treat such a problem.
Okay, we'll just start to talk about some examples of these obscure anomalies.
Yes.
To start mentioning this, we would mention those who started to be diagnosed at the birth room through the doctors, but sometimes, especially in places where the children are not born in well-equipped facilities, which is still common in many parts of the world, this can be missed until the child goes home and start to suffer. Exactly. What we can know of these are intestinal atresias. The word atresia would mean that part of the gut tube is obstructed. It's a missing part of the gut. As we all know, the gut or the alimentary tract of the human being is just like a very long tube that has been reshaped to take some different forms. Starting with the esophagus, which is the food tube that connects the mouth with the stomach in the tummy,
yes.
to transfer the food after we swallow it down there. This can suffer of this atresia. Usually now in the routine examination after birth, the doctors would do the suction just to remove the secretions of the birth from the mouth of the child and from his tummy.
Yes.
A thin tube is passed through his nose and mouth down to the stomach, which is his tummy, to suckle these secretions. If this tube cannot be passed down there, then there is an esophageal atresia.
Mm-hmm.
Sometimes this child is not subjected to this examination, and he goes home without knowing that he is suffering of esophageal atresia. Then afterwards, he will start feeding, and he will start milk intake, and in that case, the esophagus is obstructed, and the milk cannot go down to his tummy, but on the contrary, it will go up again and go towards his chest. If we just go and look to this picture, we can just understand what we are saying. If we look to the middle picture, this is an esophagus that is going up from the mouth upwards down to the stomach. This one as well is suffering of atresia. If we just look at its middle, then we will find it very narrow. This is an isolated esophageal atresia, but if we go to the other forms, we can see how far the proximal, the upper pouch, and the lower one can be apart, like just the second and the fourth ones. And in that case, the distance between the upper esophagus and the lower one is very long, and that would, of course, make the correction more difficult.
Well, does the level of the atresia that we have has different types of surgeries or different types of complication? Let's start with.
Yes, exactly, that's right. What we're saying that if we're having a small or short gap between the upper and lower esophagus, then usually we can go through the chest of the baby, and we just mobilize the proximal and the distal. And we usually excise a fistula, which is a connection between the esophagus and the trachea, which is the air pipe of the baby. And we have to remove this because the air goes out from this to the gut, and the gut secretions can go easily to the air system. So we excise this, and we start to get the upper and lower parts together, and we do that with stitching. If the gap is narrow and short, then we can just easily do this, and this can be done. If the gap is quite large, then there are a lot of procedures to deal with this. We can just divert the upper pouch to the neck, where the child can just get his own saliva out, so that he doesn't aspirate of it in his chest, and he just keep his respiration going well. And then we can just put him a tube feeding to his stomach directly, so that he can have his milk and food just directly to the stomach. And then we can do a replacement for the esophagus with another part of his gut. We usually use the colon or part of the stomach to do this replacement, and then that would be done in a later stage, maybe at the age of 4 months to 6 months nowadays. In the past, we had to do that later than that. Some other new techniques to elongate this esophagus, despite its long gap, are now available.
So the child can stay feeding through a tube into the gut for about 4 months, and he can still grow and thrive?
Yes, actually, in that case, the child is having no problem with feeding, because we can just give him as much feeding and as much concentration at what time that we need, because we are not trying to convince him to start suckling. But we have to take care that in that case, the child may get overweight, or he may be neglected to be underweight. As well, we should not forget that we have to give the child an artificial bottle or something to have suckling on it, because otherwise he may lose the instinct of suckling, and afterwards he may maybe have some problems.
And at that period of time, the child is dismissed and goes back home, or he has to stay at the hospital for
Yes, he goes home. He really goes home for this few months afterwards, when his wounds are clean and his general condition are fine, and he's starting to have the full amount of feeding properly through the tube, and the parents are well taught to deal with it, and then he goes home and stay there with frequent follow-ups in the outpatient clinic until when he passes his critical period, and then he comes again for the definitive procedure.
So what other problems that the child could have and it's still obscure, and the parents would need to diagnose it or to notice it?
Some other problems would include very commonly other atresias of the small intestine. This may include the duodenum, which is the first part after the stomach, and in that case the child would start first presentation when he goes home and start feeding, he starts vomiting, and the vomiting is continuous. After each feeding he starts to vomit, and one good characteristic of this type of vomiting is that it's bilious. What we mean bilious is that it contains the secretions of the bile, which is greenish in color, and that's quite easy to diagnose. The duodenum, the jejunum, which is the part of the small intestine following the duodenum, and then the ileum, which is the third part of the small intestine, they all start with this. The more proximal the obstruction or the atresia is, the more frequent vomiting is, and the less abdominal distension is. And the further we go, the later vomiting we will have, and the earlier distension we will have. So all of these will need surgical intervention, and all of these will need it as soon as possible to maintain the oral feeding as early as possible, so the child can catch up his feeding properly.
What other problems you can give us?
One very important thing is that some children are born without a normal anus to defecate of, and that we call them the anorectal malformations.
Yes.
Instead, like in this picture we can see now, instead of having the anus in the normal form shown by the blue arrow, this anus can be moved to a small fistulous tract through, like those in the orange arrow or the green one, or it can have no anus at all, and the GIT would end high up there and may even communicate with his urinary system.
So how could this be possible? How could he defecate? That could be a problem.
Actually, he can't. Actually, he can't. And
yes.
In that case, we have to intervene as early as possible according to the level, whether we do a direct correction of his anus from below the neonatal period, or if it's a high up, we just do a form of diversion for the colon to the abdominal wall, where he can get his stools out of there and his general condition improve, and when he grows up we just do a correction from below.
So what other advices can you give to the parents to sum up our problems? Apparently some of the obscure problems are really in need of urgent intervention. Other would need maybe some preparation before we do that. But generally speaking, what would you advise the parents to do or to notice in their children while they're growing or just after birth, to know that they have some problems? To sum up the features of such problems.
Okay. One good advantage of being in the 21st century, in addition to all the hazards that we have, is that we have now an available and good medical service everywhere. So please just get in contact with the pediatrician as early as possible. We can go to the doctor and the doctor assures us that our child does not have any problem and this is no problem. But if we just neglect going there and we're having a problem, then this can be serious. So please stick to your doctor and have some happiness with your child, and don't worry and don't panic.
Inshallah, inshallah. Thank you, Dr. Muhammad El-Debeiky, for your enlightenment about such problems. Dear viewers, I'm afraid our program is coming to an end. We would like to thank our guest, Dr. Mohammed El-Debeiky, consultant of pediatric surgery, Ain Shams University in Cairo. Until we meet again, don't forget to contact us, ask us, and send us our emails at health@huda.tv or log on to our websites huda.tv. Until we meet again, be happy and Assalamu alaikum wa rahmatullahi wa barakatuh.